If the slides could keep going. So first of all, a bit of background about the BURST Research Collaborative and where we came from. So we've all been here. Research, whilst you're doing full-time clinical practice, is hard, especially when you don't have the infrastructure to help you and you don't have the time. So that's why we founded BURST, which stands for British Urology Researchers and Surgical Training. And we're composed of an international network of urologists, trainees, and allied health professionals whose aim is to produce high-quality collaborative audit and research and provide the education to do so. And the key principle is that we're trainee-led and we produce methodologically robust work from our peer review process. And we know this works. So when you have a small amount of work done by a large number of people, the end result is big and usually more meaningful. This has benefits to the individuals as part of the collaborative who gain transferable skills from each other. It has benefits to the units to which these individuals are attached because they have the kudos of being associated with the study. The quality of work hopefully goes up, and most importantly, the patients benefit from this. And really, as British trainees, British Urology should be proud of us because we're leading internationally on trainee-led collaborative research. That too, I'm grateful to the SAC and Roland Morley for allowing collaborative research to count towards your CCT guidelines, and that change was quite important. I'd encourage international organisations to follow a similar pathway. So when I founded it in 2015, we had 3 committee members. Today we have 21. So they're spread across the UK, and you can see people who are consultants, just becoming consultants, people who are just getting their registrar numbers. You can see people who are just starting to become a doctor. And I'm very happy to have our medical student committee here with us as well. So thank you for making it up to Glasgow. So although we're British in core, we're actually international and global. And we're very grateful to our international partners who have allowed us to carry out our projects and spread the word. And really, thanks to their efforts, we've presented across the world, and in the last few years, 24 national or international presentations with a 50% conversion rate to a prize, 8 publications, and over 1,000 collaborators involved. So really, that's a credit to everyone from the collaborative who has helped. So we're going to talk about some of our work in detail in the rest of the session, but I just wanted to touch on 1 or 2 successes which we should celebrate. So first of all, MIMIC. So MIMIC is entitled a multi-center cohort study evaluating the role of inflammatory markers in patients presenting with acute ureteric colic. And I'm very proud to say that this was published in the British Journal of Urology not too long ago. And as per our typical authorship policy, if you do the work, you get rewarded. And you can see the PubMed Index collaborators listed there, which all counts on their CV. So this really was an opportunity for us to improve the management of renal colic, and we thought if we knew what factors would predict whether a patient passes stone spontaneously, that might help you influence how you manage that patient. If there was a biomarker that could be easily measured on patient admission, that could be used, that would be perfect. White cell count may have been that biomarker, and some of the previous literature showed that it may be associated with spontaneous stone passage, but the evidence was quite poor quality. So we carried out a multi-center cohort study assessing patients coming to A&E with a CTKEB confirmed stone and followed them up for up to 6 months. This project took just over 2 years from proposal to analysis, and although the development phase was key in making sure the project was methodologically robust, the recruitment stage was actually very quick, and to our amazement, we managed to recruit over 4,000 patients in 4 months. So we showed a clear association with stone size and the odds of passing your stone, clear associations with the stone location and passing your stone. For our multivariate analysis and our primary outcome, despite what the previous literature has shown, we showed that white cell count was not associated with spontaneous stone passage. We showed that stone size and position were important, and we're currently in the process of creating a risk calculator, which will hopefully be available to clinicians soon for them to counsel their patients. The second project I just wanted to touch on was a systematic review. So I'm also very proud to say this has been accepted for publication in European Urology. And the most important thing about this project was the collaborative aspect to it. It was BAUS-led, so all of the reviewers were part of the BAUS committee, the BAUS network, and they're spread across the country and even some across Europe. And you had consultants working with F1s, and we went through over 8,000 articles, and in pairs we narrowed them down to the final articles of full text review. They resolve conflicts remotely by Skype, and we use software such as Covidence, which you can see an extract from there, which allows us to work in continuum across time and space. So we're pleased to show that MRI-targeted biopsy detected more clinically significant cancer than systematic biopsy in this systematic review. Hopefully this will now form part of the EAU guidelines when they next do their review. So you really, as trainees, have an opportunity to change practice. So just to mention on other opportunities, so really, we are here for you. If you're interested in doing something, if you have an idea, you can come to us. You can drop us an email. We have project proposal pro formas on the website. The full list of opportunities are listed on the website, but for those of you who want to lead an idea, you're more than welcome. For those of you who want to take part in a steering committee, you're more than welcome. And the one thing I would say is add us on Twitter. We send out all of our notifications via Twitter, and add our email to your safe senders, which is bursurology@gmail.com. Particularly if you're a new member or even if you're an existing member, let us know a Gmail address, and we find that Gmail addresses make it through the spam filters more easily. If you're interested in peer review, we have some peer review opportunities, just let us know. And recently, we've started a new initiative with partnership with the BJUI, producing some podcasts for NICE guidelines. And these are viewed thousands of times in a short time space, so opportunities for you there as well. Social media is everywhere. We have our Instagram account now as well. Follow us at Euro Collaborative. And please do join us for the dinner tonight, for those of you who have pre-registered. There might be some spaces depending on whether they collect a ticket, so stay behind at the end if you're keen to come and you don't already have a registration. Thank you to all of our supporters, particularly BAUS, who have supported us from day one. And I'll leave you with the plan for the rest of the session, and I'll hand over to Tamer.
Brilliant. Thank you, Viru. I think there's two bits of housekeeping we need to go through, and Viru's touched on the first one already, which is we are having our burst dinner at Bladder restaurant this evening, which I've been told has got 4.5 stars on TripAdvisor, and you can see Kieran for tickets at the end of this session. And the second bit is about the app. If we can bring up the slides, please. So all of our sessions are going to be quite interactive. There will be polls, and you'll have an opportunity to ask questions using the app. So if we could all log in, find the session, and get ready for the polls, because there's quite a few coming up over the next hour and a bit. So thank you, and I'd now like to introduce Sinan to start the afternoon off with his talk on Identify.
Thank you, Tamer and Viru. So hello and welcome to our burst session on Identify. Many of you here hopefully will have been involved in this study, and it's a pleasure to be sharing the primary results with you in more detail than if you've heard it before in the Bladder session. So there'll be two talks delivered by myself and Kevin, and they'll be interactive, so we hope you will engage in the live polls and the Q&A sessions. We'll be talking about the background of the study and share some primary results, which will take us on to Kevin's talk on the implication of these results. So just a bit of background. As you know, hematuria is the most commonly investigated symptom in urology. But this can be expensive, burdensome, and invasive to our patients. Sometimes it feels as though most of the patients you see go through the same rigorous tests with very low cancer diagnostic yield. There are guidelines in place, but these are varied, and we do not really know what their impact on diagnostic yield is. So the BAUS Collaborative delivered a global study called Identify, looking at new patients presenting to secondary care with suspected urinary tract cancer, and we excluded patients with previous or known urological malignancy. So it was a multi-center international collaborative research study, and we assessed the outcomes and diagnostic pathways in these patients. Our aim was to evaluate the current practice and look at the prevalence of cancers throughout. Hopefully, using that data, we can recommend changes in cancer diagnosis pathway and therefore reduce the number of invasive procedures, waste of resources, and optimize use of the most appropriate tests. So it was a prospective cohort study. It was a trainee-led, and we used an online data collection tool to look at demographics, presenting history, cystoscopy, and diagnostic test results. So recruitment started in the UK and quickly spread throughout Europe, North America, Asia, and Australia. And soon we had sites in every country, well, every continent. It would be nice if it was every country. And this really is a true testament to the power of collaborative research. So recruitment took place just over a year and far superseded our predicted timeline, as you can see, and it left us with just over 11,000 patients in 1 year. So following data cleaning, we were left with just under 11,000 patients for analysis. These were in 110 sites in 27 countries. Our population consisted mostly of men with a median age of 66. And 2/3 of patients seen had visible hematuria, the other third made up predominantly with non-visible hematuria. Interestingly, more men presented with visible hematuria and more women with non-visible hematuria. So, to warm up your thumbs, please take out your phones, and we'd like to start with a simple question. Here we go. The first question: what is your first-line imaging combination for non-visible and visible hematuria where you work? Is it ultrasound for both, ultrasound for non-visible and CT for visible, or CT for both? Please vote now. Okay, so we have the majority with ultrasound for non-visible and CT for visible, followed by ultrasound for both, and then CT for both at 11%. So we'll go back to our slides. This is how it compares to the data from our study. So most sites actually performed ultrasound for both, and a quarter of the sites for ultrasound for non-visible and CT for visible, and very few use CT as both for first-line imaging. So here are the global overall rates of cancer from the study. Bladder cancer rate was just under 18%, upper tract, renal cell, and prostate all being approximately 1%. And as you can see, the majority of these cancers in each group were found in patients presenting with visible hematuria. Again, to highlight the contrast in cancer rates between visible and non-visible hematuria, we can see here that bladder cancer rate in non-visible is around 5% in comparison to 22% in visible hematuria. And similarly, across the other groups, there's a large difference in rates between these groups with very small cancer rates for upper tract disease in non-visible hematuria, so about 3 to 4 per 1,000. If we look at our global rates by age, there is an increasing trend with age for bladder cancer, and especially low rates in the non-visible hematuria group, in those less than 50 particularly. And upper tract urothelial carcinoma also increased for age. Renal cell carcinoma, however, peaked in the 50 to 60 year age group. And this is quite a striking graph. If you look at the upper tract urothelial cancer by type of hematuria and age, we can see that there is an increasing trend, but in the whole study, no one under the age of 60 with non-visible hematuria had upper tract urothelial cancer. So, another voting live poll, please. Mainly a test of your knowledge. What is the recommended age cutoff for investigating a non-visible hematuria in the NICE referral guidelines? Please vote now. Very good. Most of you got it right. It is, of course, 60. I think some of you are getting confused with the referral guidelines for visible hematuria. It's getting better, right? We'll go back to our slides. So, of course, for non-visible, the guidelines suggest that for those aged over 60, they should be referred. NICE also add dysuria or raised white cell count. So I'd like to move on and focus on the NICE guidelines and UK-specific data, which approximately accounted for half our data set. So we'll compare the two. Looking at bladder cancer for the non-visible hematuria group, there was a global rate of 5.1%, so we keep that in the background. And when we followed the guidelines, which I've loosely applied just with age, we find that we picked up 30 cancers for just over 1,000 investigations. That's a 2.8% rate. And if we look at those under 60, out of the 640 patients investigated, there were 7 bladder cancers detected. To share some descriptive data about these 7 patients, all were in their 50s, mostly men, mostly smokers, and the 2 non-smokers had low-risk bladder cancer. And none had dysuria or a raised white cell count, although there was some missing data with the bloods there. Similarly, for upper tract, a very small rate worldwide, matched with the UK rate when adhering to guidelines. And as mentioned previously, no one under the age of 60 had upper tract urothelial carcinoma. Finally, looking at visible hematuria, so the guidelines are over 45. And again, I've loosely applied the UTI rule here. So with a background detection rate of 22.8% worldwide, the UK had an 11.5% rate. That's almost half in comparison to the worldwide data. There was a small rate of bladder cancer picked up in those under 45 years of age. But again, there were some risk factors that would make you want to investigate them. Regarding upper tract urothelial carcinoma, comparing to the background worldwide detection rate of 1.6%, our guidelines to investigate those over 45 captured a 1.3% rate of upper tract cancer. And no one under the age of 45 in the UK had upper tract cancer with visible hematuria. So, in summary, we have the world's largest series on patients presenting with hematuria. We found very low cancer rates in non-visible hematuria groups, both worldwide and UK-based, although it seems that the UK rate is lower in comparison. And we have to ask ourselves, could this be over-investigation? What do these results mean to you? So, in order to start exploring these questions, I'll hand over to Kevin, who will hopefully challenge you and your practice.
So thank you, Sinan. So Kevin will now delve a little bit deeper into the data and tell us what the future holds from Identify. If we can save all of our questions for the end, we'll have some time to go through them all.
Hello. Thank you very much. What I'd really like to do is look a bit more into this question that we all maybe have a gut feeling about and see if we have any evidence from the Identify study which can answer the question, are we over-investigating hematuria? And if we are, how can the Identify study and the data therein help us develop a more targeted approach to the investigation of hematuria? And we would like to get your input and your ideas about how we might be able to do that at the end of the talk. Again, there'll be more polling in this talk, so please keep the app open and poll as they come along. So, I'd like to know if I am preaching to the converted. Am I going to have a hill to climb today? Do you think that we over-investigate hematuria in general? Vote now. All right, so we've got an overwhelming majority for yes. So I might have a slightly easier job today, but I don't think we should ever just go on gut feelings. We should have evidence to back that up, and let's see what I can show you. Inherent to the idea of reducing over-investigation is the management of risk. And this is a difficult thing to ask about and a difficult thing for both clinicians and patients to conceptualize. But if we had to take a simple scenario of below what level of bladder cancer risk would you be happy to not do a flexible cystoscopy in your patient? Vote now. Okay, so understandably, we're all pretty conservative about, inverted commas, missing cancers. We're looking for risks as low as 0.5 or 0.1%, which really is pretty stringent in order to forego an investigation for cancer. And we'll come back to this idea a bit later. So let's look at some facts that Identify has been able to tell us about the investigation of patients with low risk for cancer. So there were about 1,300 patients in the Identify study with non-visible hematuria aged less than 60. They all had a flexible cystoscopy. Only 40 of them had bladder cancer. Half of the bladder cancers were actually seen on ultrasound scan. There were 5 RCCs that were all seen on ultrasound scan. 450 of these young patients with non-visible hematuria had a CT scan, and not one of them had a cancer that a CT is required to find, as Sinan has pointed out. Doing CT scans has consequences. There was this study in JAMA in 2017 that demonstrated in patients with non-visible hematuria, replacing ultrasound scanning with CT detected just one additional cancer at a cost of $6.5 million for every cancer detected. Despite what our probably soon-to-be leader would have us believe, there's not going to be £350 million a week to spend on CT scans. And another study has shown us that this is not just about the economic argument. When you investigate patients at low risk of cancer with CT scan, this study actually showed that you cause more cancers than you find. And it's not just about CT scanning. The idea here is that if you apply a broad, one approach for all strategy to all patients, it becomes riddled with problems when you apply that at scale. So in the Identify study of 11,000 patients, about 2,400 patients had an abnormality on flexible cystoscopy that was thought might represent bladder cancer. They all had rigid cystoscopies with a general anesthetic to clarify. 518 of those patients were either found to have no abnormality or have a benign finding on histology. So 22% of them had a rigid cystoscopy that they probably didn't need. So the point is, investigating patients has consequences. So let's examine the question of over-investigating a bit more. Using data from the Identify study, can we find some evidence that this is actually happening? The rate of all cancers in patients with visible hematuria in the UK in the Identify study was 14%. I don't know about you, but I remember learning for exams, this number was something like 25-30% rate of cancer in patients with visible hematuria. But we're detecting 14% in our clinics. And what's astonishing about this is that in the UK, these are UK hospitals. Each hospital had an average of 100 patients per hospital, or 61 visible hematuria patients. The detection rate ranges from 3% all the way to 24%. This is all within the UK. There's no way that local cancer incidence rates vary that much to explain that difference. This is about patient selection. The groups within those hospitals are a little small in order to be able to investigate the trends more and understand why this difference exists. So we can use country-level data to investigate these differences a little more. So this graph will show the detection rate of all cancers in all patients referred to clinic across the world in the countries in the Identify study. And we can see that it varies hugely. In Australia, 5% of the patients they investigate were found to have cancer. In Portugal and Hungary, almost 50% of the patients were found to have cancer. Iraq and Japan are slightly unique cohorts, and we should probably consider Portugal and Hungary as top of the range here. There are a multitude of reasons why we might see these differences. A very simple one, as you might expect, if you investigate more non-visible hematuria, you accept more non-visible hematuria into your clinic, you're going to overall have a lower detection rate for cancer. And if you investigate slightly older patients, you're going to find more cancer. Let's look at Spain. 40% of the patients that they investigate in their hematuria clinics have cancer. This is a pretty decent cohort from Spain, 800 patients from 5 hospitals. Only 10% of the patients they investigate have non-visible hematuria, and their average age is about 68. In the United Kingdom, we detect 10% of the patients that we investigate have cancer. 35% of them have non-visible hematuria, and they're about 10 years younger than the patients that they're investigating in Spain. This is not just about how much non-visible hematuria we accept into our clinics. If we look just at patients with visible hematuria, the trend is exactly the same. So even amongst patients with visible hematuria, there is selection happening. But surely this can just be explained by differences in the incidence of cancers in that population in that country. Surely that would explain it. So we can look at that as well using World Health Organization data and looking this time just at bladder cancer and comparing every other country to the United Kingdom. So this shows the relative incidence of bladder cancer in that country compared to the United Kingdom. Look at Greece. The rate of bladder cancer in Greece is 3 times that in the UK. We can then plot the relative hematuria clinic bladder cancer detection rates and see, for instance, in Greece, where the incidence in the population is 3 times higher, they detect 3 times more in their clinic. So that makes sense. You might explain it by the increased population incidence. But look at Spain again. The incidence in their population is only twice that of the UK, but they detect 5 times more cancer in their clinics than we do. Or Portugal, where the incidence is exactly the same, and they had about 300 patients in the study. They detect over 5 times more cancer than we do. The point is the difference in these detection rates can't be explained by differences in the population incidence. But what you might say is that surely doing more investigations, screening the hematuria population more, is going to have a benefit in terms of reducing the amount of advanced cancer that we find at presentation. So let's examine if that's the case. We just looked at bladder cancers, and we defined high-risk bladder cancer as cancers that are muscle invasive or G3T1 or CIS, so reasonably high-risk bladder tumors. And here we can, in the blue line, you have the rate of all bladder cancers in the clinics in that country. And we can then plot the proportion of those bladder cancers that were high-risk bladder cancers. And what we find is that there's no real correlation between the detection rate in clinic and the proportion of cancers that are high risk. In fact, if we look again at Spain, where 40% of the patients that they investigate have bladder cancer, and about 40% of those patients have high-risk cancer. In the United Kingdom, 7% of the patients we investigate have bladder cancer, but exactly the same proportion have high-risk bladder cancer. So the point is, we're doing more negative investigations, we're screening more, but we're not gaining with reduced rates of advanced bladder cancer at diagnosis. What about the healthcare systems? What's different there? So we can again use some World Healthcare Organization data to rate a healthcare system on its quality and how easy it is to access. We hypothesize that if you have more access to healthcare, you're going to have lower cancer detection rates in your clinic because more low-risk patients are getting investigated. And that's exactly what we found. a really tight correlation between how easy it is to access healthcare and the detection rate of cancer in your hematuria clinic. So the point is, in the UK, we do lots of negative investigations. It's not the case in all countries. And the goal of Identify is not simply to reduce the amount of investigations that we do, but to do the appropriate investigations in the appropriate patients. So let's have another poll. This time think about negative investigations. What would you think is an acceptable number of negative flexible cystoscopies to be getting through in your flexi clinic before you find one bladder cancer? What do you think? Vote now. Maybe registrars, consultants might have different ideas, but we can't separate you out.
1 minute, Kev.
Okay, so the most people here would be happy to do 49 flexible cystoscopies to find one bladder cancer. That's a lot of cystoscopies. Actually, right now we're doing better than that. I said that we're finding about 7% bladder cancers, so we're doing 1 in 10, 1 in 20. But happy to do 49. Interestingly, most people, when they were thinking about the acceptance of bladder cancer risk, wanted a risk as low as 0.5%. So that's, once you come around to thinking what that means, we're not so consistent in our thoughts about risk. So in summary, practice varies hugely. Cancer detection rates vary hugely, not just across the world, but within the UK. The cancer detection rates can't be explained by the population incidence of cancer. 90% of the investigations we do for hematuria in the UK are negative for cancer, and that's 98% for non-visible hematuria. Doing more negative investigations doesn't seem to reduce the rates of advanced cancer at diagnosis in this case. Investigating people at low risk of disease has consequences, not just economic. So what we'd like your help on now is, given we've got this big data set, and we certainly have our own ideas about how it should be applied, we want to think about how practically to go from a situation where we just investigate everybody with the same investigations to where we can have a much more targeted approach to hematuria investigation. To spark that conversation off, we'll just have one last vote. And this is about what would it take to change your practice in what you do for the investigation of hematuria. So if there was a well-validated risk calculator based on a cohort of 11,000 patients, would you use it, and would that be enough for you? Do you need to see an RCT that compares the risk calculator, shows that it maintains cancer detection rates, but reduces negative investigations? Or do you think that really this is always going to be a case of individual clinical assessment and nothing like this is ever going to make you change? Please vote now. Okay, so that's really interesting. Almost 70% of you would like to see an RCT. And that's a really interesting place to start the discussion, I think.
Brilliant.
Thank you.
Brilliant. Thank you, Kevin. I think this sort of data really makes you think about the sheer number of investigations we're doing, probably in patients, particularly in patients with non-visible hematuria. Quite like to open this up to the audience now, and we'd like to focus, we've got questions on the app, so we'll go between the audience and the app, and quite like to focus on that last question on, do we need an RCT, and if we do, how does everybody think we should implement this sort of project and this sort of calculator within that setting? So any questions from the audience? In which case, I'll go from the app. And a good question from the app is there, well, this kind of, it's a linked question. So is there any data on whether the cystoscopy was performed by a trainee or by a consultant? And do we have any similar data from countries such as Spain, who have a higher diagnostic yield?
Yeah, we do have that data actually. So we know the not just the grade of the patient doing the cystoscopy, but also their experience level. For the diagnostic flexible cystoscopies, we haven't analysed that data yet, but I think even if we did find that the consultant cystoscopies had a lower false positive rate, is it realistic that we're going to have consultant supervised or consultant led flexible cystoscopies at all times? I'm not sure that's realistic. So this is what really happens, and I don't think the people doing the flexible cystoscopies are ever going to change.
Okay, so next question from the app. So, a good point. Surely we should be asking GPs about this, as they're the ones taking the risk of not referring. What do you think about that, Kevin?
So I guess this is where the NICE guidelines try to come in, and with regards risk, it's interesting. NICE have set the threshold of 3% risk in order to recommend a 2-week urgent cancer referral from a GP. So 3% is about 6 times higher risk that NICE will accept than what we will accept in terms of bladder cancer risk. That's where they make their cutoff, about 2-week wait referrals. So that's kind of the GP's point of view with regards risk. So if we could show that a patient had a risk of less than 3%, which is basically almost everybody with non-visible hematuria, then they would come off the urgent 2-week wait.
The other comment to make about that is that obviously our data is looking at patients in secondary care. And we know from, although we've kept it separate, but the no hematuria group that are coming through, obviously some of those are incidental findings, but a few of those patients are also patients with suspicious symptoms with no hematuria. And there's clearly some sort of triage being performed in primary care where GPs are doing their own screening based on good clinical acumen before these patients get through. So we just have to be careful with what we come out with in terms of the outcome of our study and the translatability of that into primary care.
Got a question from the audience over there.
It's just about the countries like Spain that you highlighted. Is it because of general practice referrals that there's a difference, or is it secondary care approach, or secondary care physicians discharging hematuria and not investigating, or is it that the GPs are not referring in to secondary care in Spain?
I think it might be a combination of both, actually. We have been trying to set up a teleconference with our Spanish collaborators to have a really good thrash out about what it is they're doing differently. And I think a big part of it is they don't refer non-visible hematuria very much. That's very clear. And what's different in visible hematuria, we need to get to the bottom of. You're right.
Okay, thank you, Kevin. So now for the next 10 minutes, I want to give the committee a chance to showcase what they've done over the past year and tell you what they've been getting up to. So if I could ask the committee to come up and the slides to start.
Hi, I'm Alex. I'm one of the new med student reps, although I'm actually due to graduate in a couple of weeks. I've been mostly involved with BURST in their communications team, mostly in designing graphics and preparing tweets to publicise BURST at events like EAU and BAUS as well. I've also been involved in our collaboration with BAUS to try and improve urology awareness as a career amongst medical students. And lastly, I've also had a hand in designing, helping to design our new torsion consensus study. Currently, there is quite a few techniques available for orchidopexy, and we've got a systematic review and submission that are showing that there's no strong evidence to support any one particular technique. And so in situations like this, consensus meeting with experts can be quite useful. And so hopefully through a modified Delphi process, we hope to, by BAUS 2020, host a consensus meeting with experts to try and to determine the best practice and create consensus guidelines off the back of that. And I look forward to taking that project forward.
So, hi, my name is Kirthana. I'm also one of the medical student representatives. And alongside Alex, I've been part of the communications team by making posters for EAU and BAUS, and also been part of optimizing Slack app integrations. I've also been fortunate in that I've been part of making the risk calculator following the results from MIMIC. So, like Viru said, MIMIC basically looked at the association between a number of different clinical parameters and the chance of spontaneous stone passage. And after statistical analysis, logistic regression coefficients for many parameters were generated, which we've used to construct a basic risk calculator using a website called Evidencio. So currently we've made that calculator, and it can be embedded on a page in Burst. In the future, we're looking to make an app that could be available for free on Google Play and the Apple Store, and hopefully we can integrate the app within MD Calc as well. So this is the graph that was in the MIMIC study paper. So the two main parameters in the risk calculator is stone size and stone position. So with increasing stone size, the probability of spontaneous stone passage falls, and with a stone that's lodged up higher in the ureter, the chance of spontaneous stone passage falls. This is a snapshot of the calculator currently. So one example here, so a male with a neutrophil count of 7 × 10⁹, without hydronephrosis, without hydroureter, with pyrexia and a stone size of 5 to 7 millimeters, which is lodged in the middle ureter, would have a 53% chance of spontaneously passing the stone. So hopefully this can be used by clinicians to counsel patients on when to consider intervention. And I'm excited to see where this project goes.
Hi guys, I'm Will. I'm another medical student representative from Edinburgh. So at the moment I've been working with a few of the committee members, including Luke and a few others, to just update the website, make sure all our publications and activities are kept up to date so everyone can get involved. I've also been lucky enough to be involved with Nikita and Kenny, who are going to talk to you about the post-ureteroscope optimal stent study in a minute, and also been working with Simon on the DTORT study. I've also been working with Alex and a few other medical student representatives to increase urology awareness in medical schools. And I've been really lucky to get involved with the BURST team, and I'd advise it to any other medical student who's thinking of applying for a steering committee position, just to put their application in. I didn't think I'd get it, but I was lucky to, and I've met some great trainees through it.
Hi everybody, I'm Joe Norris. I'm a London Urology Registrar, and I'm also a PhD Fellow under the MRC. Those of you who attended the BURST session last year may have seen I had the pleasure and the privilege to pitch my project idea to the BURST Dragon's Den session. It was this exciting experience which inspired me to apply for a committee position on BURST, and in January 2019 I was appointed as the BURST treasurer, replacing Matt Jeffries, holding the purse strings and liaising with sponsors. I've also been involved with a roster of other activities, including developing existing projects and representing BURST nationally on NIHR and BSOC committees, and also doing some of my own project creation. So I've created a podcast for the new NICE guidelines on prostate cancer, which will be finished shortly. It's been really great working with this dynamic committee and dynamic team, and I'm really excited to see what the future holds for BURST.
Hi guys, I'm Kieran. I'm one of the CT2s here in Glasgow, just about to start my registrar post in August. So I joined BURST in November, December last year, and was lucky enough to be one of the co-authors with Viru on the recent systematic review published in European Urology. I've helped tailor a new collaboration with BGI Knowledge to update their website and with BURST. I've been involved in protocol writing and grant application for a new project that we're not allowed to speak about yet. And I've updated the website with a list of clinical trials which trainees can get involved with, so if you're interested, have a look at that. I really just wanted to highlight that the main benefit for me has been a lot of advice and mentorship from more senior trainees that you sometimes don't get in your normal training, and certainly a lot of advice with regards to job interviews and how to take further projects ahead, so I've really enjoyed it.
So I'm Eleanor, I'm an ST3 in the Southwest. I actually joined the committee back in 2017 as a core trainee representative, and I've stayed on as part of the core committee. This past year has been another busy one. Started off with completing the final tweaks to our new website, which is now up and running and published. But also, like Joe's already touched on, we've started a new initiative with the BJUI on the podcast series. Like Viru mentioned, we've now published 2 podcasts, and we've got 2 further podcasts in development. This is an excellent opportunity for our members to summarise the nice guidance and also get publication online after external review. So if you do want to take part, please have a look at our website, little plug there, and contact us for further instructions, or have a look there. We also had another first of hopefully many, and alongside Kenny and Eric, we instigated, designed and delivered the first BAUS research methodology session at the BAUS Core Urology course. We're absolutely thrilled to get very positive feedback from them, so we're hoping that that's also the first of very many of more to come. I'm also one of the NIHR representatives attending biannual meetings, which is an opportunity for us to feedback on burst activities, but also gather information on ongoing clinical trials and also national audits that might be relevant for our members in terms of participation. But of course, like everyone's touched on already, as a whole team, we all have ongoing input and feedback and planning into not only existing projects like Identify, but also the exciting new projects such as DTORT and Propel that you're about to hear further details on. So what's ahead is certainly promising to be a busy but very much exciting year to come.
Afternoon, everyone. My name is Luke Chan. I'm an academic FY2 in Edinburgh, and I'll be starting urology training in Sheffield later this year. Over the past 6 months, I've been involved in updating and maintaining the BAUS website. I've had a chance to present Identify findings at the RSM meeting, and I'm currently working on our next newsletter and setting up HTML emails. Overall, it's been a really great time working in this committee. I've learned a lot about research, making quite high-quality research, and working part of a great team. So I would urge my fellow FYs or core trainees to join us. Thank you.
So first of all, I'm too short for this, which is the biggest issue. So hi, I'm Meg. I'm a ST4 Reg in London, currently coming out of my training to do a PhD in prostate cancer. So like many of my colleagues that you've heard from, started in the committee end of last year, start of this year, mostly involved in the communication side of things, so that's through emails, all our social media, and also coming to meetings, so meeting our collaborators face-to-face, and that's obviously the best thing we can do. It's really important to tell people what we're doing and get people interested, and that's the beauty of events like BAUS, and also coordinating this committee, which you can see is quite a lot of people, but good people to work with. In terms of projects, so it's been great to get involved in some of our existing projects, as well as some newer projects, and work with lots of sort of peer reviewers. So we've worked with some radiologists, urologists, statisticians, and I hope that continues. But rather than just talk about myself, I think it's important to show what we can do for everybody in this room. So the key thing I think that attracted a lot of us to this committee was the people we'd be working with. And just within our committee, as Vera has said, it's a truly national and international group of people. We learned a huge amount from each other, and that experience is very invaluable. And particularly our medical students, I'm so impressed by what you can do, and you're far excelling anything that we did. But we've learned a lot about technology and sort of new apps and things that are going to be very integral to what we do. And sort of the other two arms, obviously the research aspect. So a lot of us have come from writing protocols, a lot of us are doing higher degrees, and you can learn so much about research methodology from people in the committee, and that's not what you're taught at med school and even in any of our training. The final thing actually is, even if you're not that interested in doing very sort of detailed or high-level research in the sense of doing higher degrees. This is a great clinical and professional networking opportunity for anybody that's involved. So all of our projects, we collaborate with urologists from across the country, like I said, radiologists, lots of other clinicians. So it's a great way for you to find out some more and to meet people you may not necessarily meet. And we also work with lots of other bodies, so with funding bodies, and we work with lots of other urological bodies, so the EAU, the AUA, BAUS, of course, and lots of trainee organisations. So we want to complement them, not compete with them, and we have very good working relationships with BSOT, so the old Surge or new Surge, and our European colleagues. So I urge you all to get involved.
So we've just heard from 8 out of 21 of our committee members. Can you imagine what the other 13 have done? I wanted to use this opportunity to say thank you to the committee for their hard work and making all of this possible. So really a round of applause to everyone.
I'm amazed we didn't overrun more. So the rest of the afternoon, they're interactive sessions, so keep the questions coming. There will be more polls. And we're going to kick off with Propel. So if I can have Nikita and Kenneth up to the podium, please.
Good afternoon, everyone. I'm Nikita, and I'm an ST3 in Ipswich. I'm just going to start off this talk by going from a question to a project, and that's how we started what is previously called as Propel. I'm going to possibly change the name in the future. So all of us in this room would agree that getting an idea is only the first step in a project. It's converting this into a meaningful, well-designed trial that's the toughest part. The inspiration for this project was from the conjecture of ureteroscopy and stenting that we all face as urologists in our daily practice. It's the duality of complications, whether it's patients who have been stented and come with pain or those who have not been stented and come back with pain, that compelled me to look at the evidence on this topic. To my surprise, I found quite little on the optimal stent duration and indeed the optimal patient that you can leave unstented. The definition of a complicated ureteroscopy I found was quite restricted in the literature compared to what we were doing in daily practice. Fortunately, along the same time, I got an opportunity to explore this question further as a possible project in Dragon's Den last year. Though I did not win, this project generated a lot of interest, and I was very lucky because BAUS did decide to take it further.
So what I'm going to discuss is what did we do when we'd seen this idea from Nikita. So first of all, we had a meeting with Nikita in our committee and talked about the feasibility of potentially undertaking her project. One of the things that we identified early on is that STEM projects haven't taken place because there's multiple variables and multiple factors, and identifying a primary outcome is actually very difficult. But we asked Nikita to submit a protocol as per our guidance online, which she did, and that underwent internal peer review with 4 of our committee members. From that, we then provided her with a structured feedback, and we looked at aspects which would need to be developed so that we could then undertake the project. During this peer review, we used the PICO method to evaluate the project, considered the relevance of it, which we already knew was high from the Dragon's Den proposal, but also the suitability for birth. So would you, as the trainees, be able to and want to undertake this in the future? During the process as well, I'm sure Nikita will agree that the process is dynamic and it's an educational experience for both the trainee and also the birth committee. We try and guide and steer the trainee through this new experience, and what we found was that Nikita initially presented realistically an audit of practice, and where that is then potentially developed to is considering potentially an interventional study with the addition of patient-reported outcome measures. We'll discuss this in more detail shortly. However, we said that we provided some feedback, so what we suggested was that a survey may be of benefit to get an idea of current practice across the UK, but as well as that, we had to look at the evidence. So the NICE and the EAU guidelines recommend that stents should not be left in uncomplicated ureteroscopy. However, despite this, there's still a high tendency to leave stents. But thankfully, the Cochrane review recently showed that there was, in all the trials, there was a lack of evidence and consistency throughout all the trials, and there was actually a requirement to develop a high-quality trial to better inform decision-making. Also, we asked the question on Twitter, would you be interested in joining us? And actually the response was thankfully very high, so that was good. So looking at potentially considering a project in the future, using the PICO method, we used assessing the patients. Who would we want? So this is where some of it becomes difficult. We'd be looking for patients having a definitive unilateral ureterorhinoscopy for a stone procedure. And what we have to find is those patients that are suitable to be randomized to either no stent or some form of ureteric drainage. In using the EAU guidelines, we'd apply that to uncomplicated patients. This would be patients that would have no evidence of ureteral trauma, bleeding, perforation, UTIs or pregnancy, but also, importantly, residual stone or fragments, so that their procedure is then complete. As you would agree, that should be the majority of the patients that we deal with, so that's where this should be feasible.
So I'm just going to go through a few trial designs that we've been mulling over. We haven't really decided on one of these. So the first would be a 1:1 RCT. We'd randomize these patients into either a no stent group or any form of ureteric drainage. Sorry. The second would be to randomize these patients into a no stent group, a stent and cystoscopic removal in 2 weeks, and a ureteric catheter drainage overnight. And then the third option that we have been considering as well is a MAMS protocol, which is a multi-arm, multi-stage trial. We'd randomize these patients into the no stent group, something like an open-ended ureteric catheter, the cystoscopic removal, stent on strings, and then newer options as they emerge. And obviously, because it's a MAMS trial, you can also drop older options if they show no efficacy. The objective of such a trial primarily is to see if not stenting these uncomplicated ureteroscopy patients is superior to routine ureteric drainage in terms of type and duration of comparable drainage. We want to focus this on patient-reported satisfaction or PROMS. Something that I really like is the CUSP trial from Cambridge, because it looks at stented and unstented stone patients. And we also then want to look at secondary objective of reducing 30-day readmission rate. But we all would agree that this is a massive undertaking. It's going to take a lot of time, energy, and resources. So we first need to find out whether it's worth it, which is why we have launched a survey that a lot of you must have either seen on Twitter or through our mailing list, which is essentially to assess the uncertainties around the feasibility of such an interventional study. What we want to know is whether you, our collaborators, are willing to randomize these patients. We also want to then find out, as a secondary objective, what is the current view and practice around ureteric stenting after uncomplicated ureteroscopies worldwide. And then we're going to tease out a lot of other things from this survey. So why do this survey? It's an easy 10-minute process. It's on RedCap. It's anonymous. It's been very well thought of and well designed with the BAUS team and 5 external peer reviewers. It's really important for us, as you've heard before through all the talks, to engage you all, because you are our future collaborators, and we want to know what you think, so which is why we want you to do the survey, please. It's open for 4 weeks. The deadline is the 24th of July. You might have seen it on Twitter and the BAUS mailing list, but if you haven't, you can open it today. So, sorry, if you go onto the BAUS session on the app, just below our session, there's a link to the survey. So you can open it right now, save it, and do it later. Thank you.
So if there's any burning question, we've got time for just one. Otherwise, we'll move on to the next session. Okay, thank you, Nikita and Kenny.
So the next 2 talks are from Simon and Arjun, and there are another exciting project that we have in the pipeline called DTORT.
Good afternoon. It's a pleasure to be back presenting in the BAUS session. I'm Simon Morton. I'm a registrar working with BAUS training in the Northeast. Last year I entered the Dragon's Den and won the competition, and I'll touch upon again that later in my talk. This is an interactive session. We're coming to the latter stages now of the DTOR protocol, and we're hoping to get some excellent feedback from yourselves today regarding the project. So I'd like to start off with a couple of questions, please, on the polling. So just a reminder for anyone who's just entered how to set up for the polling questions. And the first question is, overall, we perform too many scrotal explorations for possible testicular torsion, yes or no? Please vote now. Right, okay. Second question, in your clinical practice over the past year, what proportion of scrotal explorations were negative? Greater than 75%, 50 to 75%, 25 to 49%, or less than 25%? Please vote now. Okay, interesting. Hopefully I can explain a bit more about this. So I entered the Dragon's Den last year. Throughout my training, from being a core trainee to a registrar, I felt that we were doing too many explorations that were negative, i.e. there was no pathology found whatsoever. And speaking to colleagues and consultants, I got the same feeling from them. So when I rotated to the Freeman 2 years ago, I got discussing with Chris Harding, we decided to do a multi-centre project in the northeast. And the key things I wanted to take from 116 patients, we found a 30% negative exploration rate. There was only a 20% torsion rate. And the other thing I noticed was 41% of the patients got occulopexy. So there was patients getting occulopexys for no clinical indication, which I found a little worrying. So acute scrotal pain is common. It's very rare to be on call and not have to deal with acute scrotal pain. And then what are we doing with regards to investigation management, nationally and internationally? If you look through the published literature, negative exploration rate is poorly reported. And why do we need to reassess this? Too many explorations for negative pathology. Occulopexys are not required, I've just alluded to that. Improve patient outcomes, avoid complications. Surely we can do better. We shouldn't just be taking patients to theatre just to explore them. And better use of resources. We still are in austerity. So last year, this is my proposal from Dragon's Den, and essentially I want to do everything, assess how the patient was arriving to the hospital, any delays, for example, in referral, their entire journey throughout the hospital, and then a follow-up. And so with BAUS this year, we've been discussing amongst ourselves and with radiologists. I've been to the National Collaborative meeting in Manchester, to the research clinic. And so we're still interested to look at demographics and try and see the symptoms, etc., that patients are presenting with and clarify a negative exploration rate. I'm going to come to ultrasound in a second. With regards to management, it's one of the medical students already mentioned earlier, Sasha Moore presented in Barcelona this year, the systematic review showing that occulopexy, there wasn't much difference between the different techniques, so we felt we're not going to look at this again. And in my study that I did in the northeast, we only had a 72% response rate with follow-up at 6 weeks. And there's been a lot of previous studies looking at atrophy rates and hormone profiles. So we wanted to try and think of something new and to evaluate the process. So we decided to look at the ultrasound and using the PICO model here. We're going to include patients of greater than or equal to 2 years of age undergoing scrotal exploration with no history of trauma. The key thing is here, they have been reviewed and they're already going to theatre. And if they decide to take part in the study, we'll then do a scrotal Doppler ultrasound scan by the registrars themselves. So we're going to exclude radiologists. And those patients we've already decided are going to theatre. The comparator will be what our findings at theatre when we explore them. And the key outcome will be the accuracy of the scrotal ultrasound carried out by registrars themselves. The thing is, a lot of the previous studies have looked, it's often been radiologists doing the ultrasound. We want to actually put it into the hands of the operative surgeon. And I've just added there as well setting. It's going to be in secondary care. We're not going to look at any follow-up out in the community. And extrapolating that further, the primary objective will be to investigate the diagnostic accuracy of scrotal ultrasound by surgical registrars in patients undergoing emergency scrotal expiration and compare to definitive findings at theatre. Hopefully we'll determine current clinical practice regarding investigation and management of patients presenting with acute scrotal pain. We'll be able to determine the incidence of negative expiration rate, and what I would also like to see is there any impact by the registrars doing the ultrasound on the negative expiration rate. We'll be able to assess the predictive value of clinical features. There's been previous scoring systems reported, so hopefully on a larger scale we can address this. And again, we can look at the statistics of Doppler ultrasound for the detection of testicular torsion. And like any study, what are the potential benefits? We can investigate the diagnostic accuracy of scrotal ultrasound by registrars and patients in a large national multi-centre study. The key thing is we'll be able to assess the impact of scrotal Doppler ultrasound on negative expiration rate. And the following point I really like, trainees will benefit from participating in DTOR. We're going to teach them how to do scrotal Doppler ultrasound, so they'll enhance their clinical and diagnostic skills. This may be a stepping stone to developing these skills further into more ultrasound techniques. And by training registrars participating in DTOR to perform the ultrasound themselves, we will circumvent the need for on-call radiology. This is often quoted as a factor that might lead to patients having an orchidectomy rather than an orchidopexy. So to summarise, if you're taking part in this study, the patient pathway, the patient presents with acute scrotal pain. Based on their history and clinical factors, a decision is made to take them to theatre. We then consent them into the study. They'd undergo a scrotal Doppler ultrasound scan, and then they're taken to theatre for definitive findings. So the last two slides, I just want to touch upon a few questions, and Arjun's going to discuss this further in the next session. So with regards to ultrasound training, how do we do it? And this is something we're actively discussing at the moment, in particular with Dr. Patel down in London. So we could do an online training course and look at possibly the theory to help that, and then a hands-on course. There's been previous ultrasound courses held at BAUS. We're looking into possibly doing one next year. And also, you would need to consolidate the skills in the radiology department. Speaking to senior sonographers, they're saying about 20 to 30 cases for the Doppler ultrasound. You know, I've been saying Doppler ultrasound, following discussions with a number of radiologists, grayscale ultrasound imaging, it takes a long time to train, and we have to remember that we're not radiology trainees here. So I think Doppler ultrasound is feasible. And final food for thought is the specialties to consider for participation. Obviously urology, but where I currently train, two of the district generals are covered by general surgeons. Some of them would be keen to take part. I know of one consultant paediatric urologist who's very keen to take part in the study. Also, which centres we use, tertiary referral centres or DGHs? I personally think DGHs will have a lot, we'll get a lot of patients taking part in the study there. And again, I can see equipment availability possibly could be an issue, but we have some ideas about that. So to summarise, DTORT will evaluate national practice, in particular the negative expiration rate. It will establish diagnostic accuracy of scrotal Doppler ultrasound by trainees and patients undergoing expiration. It will assess if scrotal Doppler ultrasound by trainees can reduce the negative expiration rate. It will provide training and enhance the clinical skills of trainees. And in an era of image-guided medical care, DTORT will investigate the transferability of imaging skills across specialty. Thanks very much for listening. I'd just like to acknowledge that BAUS are all part of a team, and also Dr. Patel and other radiologists and sonographers that we've been discussing with, and also Will, who designed this excellent logo. Thanks very much.
Brilliant. Thank you. If Arjun could now come up to the podium. We've got a couple of very interesting questions on the app, but we're going to save them all till the end. And hopefully Arjun's talk might answer some of them as we go along. If you can get your phones ready, his talk's slightly different. He's got multiple polls, and at the end of each poll, we actually have an opportunity to answer some questions and take some questions regarding that poll from the audience.
Afternoon, everybody. My name's Arjun. I'm one of the urology registrars working in the Northeast with Simon, and along with him, part of the planning committee, if you like, for this study, which we call DTOR. Now, you all know about this. You all know how to use the app, so we won't spend any time on that. But I found it very interesting, actually, that in this group that we have in this room this afternoon, 55% of you said that you don't think we do too many scrotal explorations. But then by your own admission, your negative exploration rate as a group, again, was 50 to 75%. Would you care to explain yourselves? In fact, just write down where you work at the back of the room so that we can make sure we don't send anybody we know to those departments. The point being that we know that there's a very high negative exploration rate for torsions, but we accept that because it's ingrained by our radiology colleagues, by our own mentors sometimes, that you never not take a query torsion to theatre. So just to clarify, can I just check, get a show of hands to see how many of you are actually urology trainees or consultants in this room? So the vast majority. So this is interesting because this is exactly the sort of group we want to get an idea of whether you would be happy to recruit to a study like this. And that's the aim of this session, because with any research project, the planning is the most important thing. You want to try and anticipate what your problems are going to be before you actually have those problems. And that's the idea behind this session today, is to try and anticipate what problems you think you might have in the design of the study or in delivering it, because ideally you're going to be a part of it. You and your colleagues are going to be a part of it. So the first thing is about recruitment. So we'll start off with this, just a general idea. How many scrotal explorations for suspected torsion have you carried out over the last year? 0, less than 10, 10 to 20, 20 to 50, or more than 50? And you can vote now. Vast majority performing about 10 to 20 in the past 1 year. That's pretty good. So bearing that in mind, think about the following questions with that number in mind. So of those patients, you know what this demographic is for your local hospital and for your local area. So going forwards, what are the sort of problems that you anticipate with recruiting that type of patient population? And remember, the demographic that we looked at when we were looking at in the Northeast, we recruited 116 patients in 3 months, which is a pretty big number. But that is a specialist center, or it includes a specialist centers. And you may have that in your region as well. But again, those are just things to think about. So the next question is about recruitment again. So based on that demographic, what do you think will be the biggest barrier to recruitment of patients to this study? Is it going to be a delay in the patient pathway, you having to explain to the parents that you're going to have to do a scan before you take them to theatre, and they're worried that that might delay the pathway? Is it going to be getting consent from the parents to participate in the study at all? Is it going to be the ultrasound training aspect of it? Or is it going to be actual access to ultrasound machines in your center? So again, vote now. So most of you seem to be worried about the ultrasound aspect, and that's reasonable. We anticipated that sort of. So let's just have a slight discussion about that now. What aspects of it? So it seems to be access to ultrasound machines, but also, it's come up equal now, training and access to ultrasound machines. So anybody got any comments about what those issues would be? Micah. Going missing, yeah. I mean, ultrasound machines, most hospitals have access to ultrasound machines. You will have an ultrasound machine, either in the radiology department, sometimes in the urology department, sometimes in theatre. It's just about making sure you have access to those out of hours, isn't it? So I suppose that's, when you're setting up a study, you would expect that would be part of the planning phase, that if you're going to be a center that's going to be taking part in this study, you're going to be talking to your radiology department, you're going to be finding out where those scanners are available, and making sure that you have access. That's something that needs to be pre-anticipated and pre-planned for. So yes, that's an important aspect to it. But as far as access to machines is concerned, we can probably get around it. And even if you're in a center who's very enthusiastic to participate and you don't have access, we could probably arrange that as well, I would hope. But yeah, that's a good consideration, yeah. Anybody else? Mr. Harding?
I was just going to comment on the delay in patient pathway bit. It's very rare that you make the decision to take to theatre as a port to there straight away.
Yeah, absolutely, yeah.
You've got that kind of sitting around time.
Yeah.
Where you can do the scan. So I think it's really important in your patient report forms to make sure that you document both the time taken to do the ultrasound scan from start to finish and whether or not it resulted in any delay in the patient getting to theatre, because I suspect in the vast majority of cases
It won't. Yeah, I would agree with you there. I think even the pilot study, or sort of pilot study that we did in the Northeast, the transfer time was about 90 minutes. I think that's a good transfer time. I think usually it's more than that. But I think if you have 90 minutes, then there's probably nothing to stop you from fitting a quick scrotal ultrasound scan in that time. But yes, we should incorporate it into the performer, yes.
We've got a question from the app as well, actually, about whether the ultrasound will be done pre or post anesthetic.
Yeah. So it will be. So there's two aspects to this. One is you do an ultrasound scan pre-getting to theatre, so either in A&E or on the ward, wherever the patient might be. You have a bedside scanner. You do the scan wherever you see the patient. The other option is you do it on table just before you actually do the procedure, so which would be under anesthetic. Now, whether we could give the option as to you could do either or, I think for purposes of this study, that might be the way to go, but that's again something we would have to think about because it is an important point. It's obviously much easier to do a scan with a patient asleep under an anesthetic, especially if you're not necessarily a specialist radiographer. Yeah, Kieran.
Most anaesthetic rooms will have an ultrasound as well, whether they're Doppler.
Yes, that's a good point. Yeah. So it may be easier to
Doppler,
access. Yeah. Absolutely, yeah. It may be easier to access the machines in the anaesthetic room. So maybe it will be a case of us saying that yes, for the purposes of this study, we do it in the anaesthetic room or in theatre.
You have to consider children.
Yes, yeah. The majority are children, so yeah, that's definitely a factor as well. Mr. Harding.
So the only thing is that this has got to be a pragmatic trial and your results have got to be generalisable, and if you're saying that you want to eliminate explorations, then the anaesthetic room won't be part of that pathway. So
yes.
Ideally it should be done when the patient is assessed. I do think you should give the option. There's a school of thought, isn't there, that the muscle relaxants, etc., might cause some detorsion. I mean, I don't really buy that personally, but I think you want to put it in a place where it might be in future in terms of clinical pathway.
Yeah.
I mean, following on from that, actually, that's a really important point, because if we're going to be doing this, we want to know, is it actually feasible in children who are in pain in A&E when we may be using the scan to make a clinical decision? So it's a really important point, actually.
Yeah, that's a good point as well. Absolutely. Yep, got a question there in the middle.
So the point of this is to see if you can reduce the number of unnecessary torsions, scrotal explorations that we do. Now, we've already sort of picked up some barriers there. Say you find, yes, if we adequately train the registrars to do the ultrasound and prevent children going to theatre, then the next step is, do we all get trained in performing scrotal ultrasound? And then secondly, you guys might provide the ultrasound machine for the study, but practically it's always a challenge to get your hands on an ultrasound machine.
Yeah.
So I'm just struggling to see how it's going to make a big difference to our day-to-day practice.
Yeah. So a couple of things there. So one is it that we struggle to get access to ultrasound machines, or is it that we struggle to get access to ultrasound, i.e. radiographer, radiologist, to do the scan? So is it that if we actually had the skills to do it, we'd be able to do it and be able to provide that service without having to resort to having to wake up a radiologist at 3 o'clock in the morning? Because that tends to be the biggest barrier. And you're always met with a steel door saying it's not going to make a difference to management. Well, if you could show that it does make a difference to management, that would give you a lot more weightage, either A, to get an expert to do it, or to say, I can do it, I've got the skills, and I can do it. And that's actually a secondary aspect to the study as well, is providing that extra skill to the trainees Because, you know, if you can do a decent scrotal ultrasound scan, that will transfer to other things as well, or could do.
One comment just to wrap things up for that question. So there is a drive in medical school curriculum to now teach medical students how to use ultrasound. So I think this is coming. I think this study looks at transitioning skills between different specialties and allowing a different set of specialists who might be managing the patient to adopt a skill set that was traditionally done by another set of people. And I think because of that, if we were able to overcome that barrier, we could change practice. Arjun, do you want to move on to the next one?
Yep. So the next question is about ultrasound training. So we all understand that we probably do need some degree of training for this to be able to deliver this study. So what are you willing to do? What sort of dedicated training in ultrasound would you be willing to commit to be in order to be able to take part in this study? None, which is not really feasible, but it's an option. 2 is an online course where you just do a sort of introduction to ultrasound, basic theory, if you like, and then you do an in-house demonstration where somebody actually shows you a few scans, and perhaps you do 1 or 2, but just over a few hours. You could do a 1-day course, which potentially could be next year at BAUS or somewhere else. You could do a more intensive 2-day course, or you could do a certification program where, again, you have a bit of online training, but then you attend a pre-specified number of cases at your local center and get signed off either by a senior radiographer or radiologist to say that you're now competent to do scrotal ultrasound scan, basic scrotal ultrasound scan. So let's know what you think. Ah, okay. That's interesting. I have to admit, I wasn't expecting that many people to be willing to commit to a 2-day course or even a 1-day course for that matter. But yeah, I mean, I think from the point of view of delivery, some local training is probably going to be the most feasible. But let's get some opinion from the floor. What do you think? Anybody?
Just one time for one from the floor. This gentleman here.
I think it depends on what we're discussing. If it's just for the purposes of this trial, I think it's very reasonable to undergo a short course or a completion of a certain number of cases. But if you're asking the registrar to base their number upon this and to say, I'm not going to take this patient to theatre, based upon the findings of this ultrasound on a kid in A&E, I think you're talking about 2 different issues there.
Sorry, can I make a point? The whole point of this project is they're going to theatre already.
I know in this situation they're always going to theatre, but ultimately your aim is to show that the ultrasound could take less people to theatre.
Sure. Yeah, I mean, just for some background, radiology trainees, on average, have to do about 50 to 60 scrotal ultrasounds to be signed off as competent. And that's in scrotal ultrasound as a whole. It's not just looking at torsion, it's looking at everything. So that's just a number for to keep in your mind as to what's considered reasonable for radiology trainees. So that might help you get your head around it as well.
Report from a radiology registrar where they've been uncertain and you still have to take them to theatre. So that's somebody who has done way above that number in the first place, and even they can be uncertain.
Just as a point, we may end up having the most experience if this becomes standard practice in detecting torsion on an ultrasound, because radiology registrars routinely, refuse or shy away from doing scans. They don't actually see them, so they don't themselves know what a torsion on an ultrasound looks like.
Yeah.
So we might find we actually get better.
Absolutely, and I agree with Tim. One of the most important aspects of surgical training is feedback, and you are the only person who has the direct feedback of actually seeing what you find at exploration. At least for this study you do. So, cool. Okay, so next question, again on equipment and ultrasound. Do you have access? Do you have access to portable ultrasound in your center? Either in your own department, in the radiology department, or in theatre. So the options are yes at all times, 2 only during the day, 3 not at all, and 4 you're not sure. So vote now. Good. Okay, so 60%, 55, 60% have access at all times, which, yes, this is going to vary between centres. I realise that, you know, if you work in a DGH versus if you work in an academic teaching hospital, your access is going to vary. But it's encouraging that many people think they would have a good amount of access required. So that's promising. I think the next couple of questions relate to one of the audience questions earlier, and we'll move on to that just in view of time, because I think it boils down to the crux of the matter, as in terms of what's going to make you change your practice. You know, most of us have said that, you know, we don't think we do too many explorations. We're probably not going to change anyway. So what is it going to take? And that's the idea of this question. What lower limit of negative predictive value for suspected torsion would you be willing to take forwards and say, yes, that's fine. Based on an ultrasound scan, I won't take somebody to theatre for a suspected torsion. Suppose we do this study and we find that on average, scrotal ultrasound scan has a negative predictive value, i.e. the probability of it not being a torsion if the ultrasound scan is negative is over 99% or 95 or 90. What level of that would you accept as saying, okay, that's fine, I'll accept that. If I get an ultrasound scan which says this is negative, it's not a torsion, I'll be willing to say we don't go to theatre. Okay.
We've got two questions on the app for you. Yeah, very
Yeah,
interesting
go on,
actually.
go for it.
So one is about training for ultrasound, and have we decided what our metric for positive, negative will be? And the other one is related to this question you specifically asked, is do we know what harm we are doing to patients who are undergoing explorations, potentially negative explorations?
So the answer to the second question is there's no actual long-term studies which have looked at it. We all know that there probably is some effect, especially because we've seen that a lot of patients who have explorations do actually end up having an orchidopexy as well, irrespective of whether they're torted or not. So that's got to have a bearing, but the answer is we don't know that for sure. Simon, do you want to?
Yeah, this is part of the reason that I did the study a couple of years ago in the Northeast, is that I have met a few patients now with chronic scrotal pain that have been explored, and either nothing was done, just open and shut, or they've had orchidopexies, and I still know some colleagues who are still doing orchidopexies if nothing is found, which I don't agree with. But I don't think it's justifiable to give somebody chronic scrotal pain for no reason.
No, I agree, and I think I don't know if we necessarily all ask the question of our patients who come in with chronic scrotal pain whether they've had orchidopexies in the past. They may have had, and again, we don't know the answer to that. But it's encouraging. It's encouraging that all of you didn't say that we'll explore anyway. So it means that potentially we could get this study off the ground, and people could potentially be interested in doing it. So that's good. Have we got somebody at the back there?
We've got one from the floor.
Hi, sorry, it's just more of a general question. Sorry if I missed it earlier, but I was wondering if there was any buy-in from our colleagues in emergency medicine. I mean, they get formalised ultrasound training and things like sort of ruptured AAAs and things like that. So, but they have a formalised process for that, and often these patients that we see are in A&Es, and they're in A&E departments, often with an ultrasound scanner. Surely, has there been sort of any buy-in from the emergency medicine side of things? Obviously, I'm sure it's a skill that they would also like to acquire.
We haven't inquired with our colleagues in the UK, but in America, a lot of it's driven. The TWIST score is the scoring system looking at history and clinical factors, and that was first established from emergency medicine colleagues. Ultrasound is used far more in the States, probably from a financial driven point of view as well. And I suspect the negative exploration rate in the States would be a lot lower. But as I say, it's very poorly reported in worldwide literature.
It also relates back to, I know that A&E trainees do get training in fast scanning of the abdomen. But again, that's abdominal scans, doesn't necessarily directly relate to scrotal ultrasound, which again, they would need training for. So is it more feasible to train them to do the ultrasound and then we take them to theatre, or just to train us to do the ultrasound scan and we are the ones that then take them to theatre as well?
And that's part of the reason we're talking about Doppler ultrasound. We've discussed with Udi Patel in great detail and senior sonographers to learn high-resolution grayscale ultrasound imaging, the scrotum in particular, to look for the whirlpool sign in the cord which can be suggested torsion, takes a long time to train up for, and even less experienced consultants might ask senior colleagues to have a look at that, which is why we're looking at Doppler ultrasound, a binary yes or no, and Dr. Patel is doable to learn that, and that's what we're currently wanting to feedback from yourselves about how we could go about it. One of the key things I think would be is an online course, and then go back and consolidate in your own department, because we are quite keen to get general surgery and paediatric urology involved as well.
We'll just move. Sorry, Michael. We'll just move on to the last one. We'll get your thoughts at the end as well. Just moving on to the last question quickly. Just based on this, what level of negative predictive value would you expect? The next question is then, would this change based on your clinical index of suspicion? Because, you know, we take the history from these patients, examine them. There are some that we are highly suspicious that, yes, this is probably going to be a torsion. And there are others that you know are not going to be a torsion, even though you're going to take them to theatre anyway. So are those figures going to be changed by your clinical suspicion? Overwhelming. So what that suggests to me is that it's not just the negative predictive value on ultrasound scan. It's important that we find some kind of, if not a clinical metric or a clinical score, at least what are these aspects of history and examination which predict a potential torsion as well as the ultrasound scanning. So it may just be a composite score, if you like.
Yeah, I think this study, because we want to look at the demographics and the presenting history and symptoms, we could be able to do some statistical mathematical modelling, and I think this study will also give a great opportunity for that.
Yeah. Ms. Hardy?
Is it worthwhile asking a assessing doctor their index of suspicion for a torsion?
Just as a sort of Likert scale?
And record, yeah, just say a visual analog scale or a 0 to 10 scale, whatever, and recording that, because as you say, we all know, oh, this is not going to be a torsion, but I daren't not take it.
Yeah.
And I think that would be a good thing to build in.
Be,
but obviously there will be other things you can build in, CRPs, white counts, etc.
Okay, Arjun?
No, I think, yep, that's
so,
it. Thank you all very much.
So thank you, Arjun. That draws the session to an end. I'd like to thank all of you for coming, and those on the live web stream who are still following us, thank you for watching. Thank you to the committee who prepared for today's session, and hopefully this time next year we will be able to shed a bit more light on what we've planned from today. Tamer?
Yeah, no, thank you everybody for coming. As I said, I've been in charge of the app, and there's a lot of questions, so if you can come down to the front at the end, there's some interesting ones here that we should probably have a chat about. So thank you everybody.
And final thing for dinner, anyone who wants to come for dinner who hasn't got a ticket, if they want to find out whether there are any free tickets, Kieran, this man here, will have a big queue for him. He'll be waiting up here on the table. Otherwise, thank you.